ADHD is one of the most common neurodevelopmental disorders of childhood. It affects both children and adults. It's described as a persistent or ongoing pattern of inattention or hyperactivity impulsivity that gets in the way of daily life or typical development. Individuals with ADHD may also have difficulties with maintaining attention, executive function, or the brain's ability to begin an activity, organize itself, and manage tasks, and working memory. It is a serious public health concern because of its high prevalence, long-term course, and functional impairment at home, school, and work. ADHD has a strong genetic component. It is inherited in an estimated 74% of patients. So, individuals with a sibling or a parent with ADHD have 2 to 8 times the increased risk of having the condition. Environmental factors are also thought to contribute to ADHD, such as maternal smoking, exposure to lead, and in utero exposure to alcohol and illicit drugs. Genetic and environmental factors together appear to shape the ADHD brain and lead to changes in brain structure, function, and connectivity. Imaging techniques have actually revealed structural and functional brain differences between individuals with and without ADHD, but there's no evidence for clinical utility. Another thing is the default mode network. It's a key finding in ADHD brain research. In non-ADHD brains, the default mode network is suppressed when a person is actively being attentive to prevent external stimuli from causing distraction, impairing cognitive and motor control. Failure to suppress the default mode network in ADHD leads to lapses in attention, distractibility, and impulsivity. ADHD is not caused by poor parenting, food coloring, or excessive dietary sugar. There are multiple comorbid conditions with ADHD, including learning disabilities, oppositional defiant disorder, anxiety disorder, depressive disorder, bipolar disorder, and tics and Tourette's disorder. Many children with Tourette's disorder have ADHD, but fewer ADHD patients have a tic disorder. Treating the ADHD and the comorbid conditions improves patient prognosis. Brain scans and neuropsychological tests are not required for a diagnosis of ADHD. Validated rating scales and symptom checklists are recommended to objectively document symptoms. These must be documented in 2 areas, such as school, home, and/or work. I've given several of these to you in your readings. You will not be tested on these, but I wanted you to have them for your future practice. The Neuropsychiatric Electroencephalogram-Based Assessment Aid for ADHD, or NEBA, was approved by the FDA to assist in the diagnosis of ADHD in patients 6 to 17 years old. It is used in conjunction with a clinician's clinical evaluation. The NEBA system has not gained widespread use due to lack of a proven advantage over standard of care using DSM-5 criteria. The DSM-5 criteria define 4 dimensions of ADHD: attention deficit hyperactivity disorder, primarily of the inattentive presentation; attention deficit hyperactivity disorder, primarily of the hyperactive impulsive presentation, ADHD combined presentation, and ADHD other specified and unspecified ADHD. There are several general criteria for diagnosis from the DSM-5. 1. Several inattentive or hyperactive impulse symptoms are present before 12 years of age. 2. Several symptoms are present in 2 or more environments. Remember, school, home, and work, and clearly impact social or work functioning. 3. The symptoms are not better explained by another mental health condition, such as a mood disorder, anxiety, personality disorder. 4. Inattention or hyperactivity impulsivity symptoms are present for at least 6 months. And 5. The patient must also exhibit a persistent pattern of inattention and/or hyperactivity impulsivity that interferes with functioning or development that is listed on the next 2 slides. The diagnosis for inattention includes 6 or more of the symptoms listed and that have persisted for at least 6 months to a degree that is inconsistent with developmental level and that negatively impacts directly on social or academic occupational activities. These criteria include: often fails to give close attention to details or makes careless mistakes in schoolwork, at work, or during other activities. For example, overlooks or misses details, or work is inaccurate. Often has difficulty sustaining attention in activities or tasks. For example, remaining focused during lectures, conversations, or lengthy reading. Often has difficulty organizing tasks and activities. For example, poor time management, disorganized work, fails to meet deadlines. Avoids tasks that require sustained mental effort. For example, schoolwork, reviewing lengthy papers, or preparing reports. Often does not seem to listen when spoken to directly. For example, the mind seems to wander. Often does not follow through on instructions and fails to finish schoolwork, chores, or duties in the workplace. Is easily distracted by extraneous stimuli, including unrelated thoughts. Often forgetful of daily activities, for example, chores, returning calls, paying bills, and often loses things, school materials, key, or wallets. Hyperactivity impulsivity diagnostic criteria includes 6 or more of the symptoms listed that have persisted for at least 6 months to a degree that is inconsistent with developmental level and that negatively impacts directly on social or academic occupational activities. Often fidgets with hands or feet or squirms in the seat. Often leaves seat when remaining seated as expected. Often runs about or climbs excessively at inappropriate times. Often has difficulty playing quietly. Often blurts out answers before a question is completed. Often interrupts others. They may intrude or take over what others are doing. There are guidelines for treating ADHD in children 4 years and older, but there are currently no guidelines for treating ADHD in toddlers. According to the NIH, ADHD symptoms can appear as early as between the ages of 3 and 6 and can continue through adolescence and adulthood. Primary care providers must weigh the risk of administering ADHD medication to very young children against the potential harm of delaying diagnosis and treatment. The DSM-5 diagnostic criteria for ADHD can be applied to preschool-age children. However, compared to school-age children, preschoolers display more hyperactivity and impulsivity than symptoms of inattention. When behavioral problems suggest ADHD, parent training in behavior management and enrollment in a preschool qualified to manage the problem behaviors are recommended. Many cases of ADHD are first identified in children between the ages of 6 and 9 years of age, with the child having difficulty academically and or socially in the school and at home. Most children have combined inattentive and hyperactive or impulsive symptoms that cause functional impairment. Hyperactivity decreases in adolescence. Inattention and impulsivity are the more prominent symptoms. Adolescents with ADHD are often identified as moody or having a temper. Higher rates of delinquency, drug and alcohol use, and coexisting psychiatric diagnoses have been documented in adolescents with ADHD compared to those without. The DSM-5 criteria for ADHD in childhood and adolescence also apply to adults. However, inattentive symptoms are the most common and functionally appearing in adults. Adults with ADHD fail to pay attention to details, have difficulty with organization, are forgetful, and have trouble following through on tasks. Adult ADHD is linked with higher rates of coexisting anxiety, depression, and substance abuse. Adults with ADHD are at a greater risk for unstable relationships, unemployment, and incarceration compared to those without ADHD. First, we are going to explore non-pharmacologic treatment. Parent training and behavioral management strategies should be provided, such as providing routine, consistent, and positive rewards for good behavior, discouraging negative behavior by ignoring it, taking away a privilege if the negative behavior is too serious to ignore, and removing common triggers of bad behavior when possible. I have given you a handout in your readings that give multiple examples. School-based interventions such as classroom seating that reduces distractions, one-on-one time with teachers, providing one step at a time directions, breaking up homework assignments into shorter segments, conveying the consequences of not paying attention ahead of time, and daily progress reports on reaching goals, with rewards for meeting them, are encouraged. Therapeutic recreational programs that teach social skills and group play that may also incorporate sports and team membership skills are also recommended. Although it varies by state, children and adolescents with ADHD may qualify for an individualized educational program that allows for more time to take an exam, preferred seating, and modified work assignments. Children with ADHD are entitled to additional help under primary education laws. Every state has a parent technical assistance center that can help parents of children with ADHD learn more about their child's rights and make sure children received an individualized education program or Section 504 plan. An IEP or Individualized Education Program. It's a comprehensive document that essentially serves as a blueprint or roadmap for a child with special education services. It includes comprehensive information about a child's diagnoses, needs, recommended services and accommodations, and pretty much anything else pertaining to the child's unique identifying factors. It's formal and legally binding and is the result of a comprehensive evaluation. A 504 plan is also a map or a plan, but it details specifically how a child will be learning within the school and does not equate to a diagnosis or even formal special education services. The name of the document arises from Section 504 of the Rehabilitation Act of 1973, which prohibits discrimination against people with disabilities who are in need of accommodations. This is issued, or the 504 plan is issued to students who are able to participate in a general education classroom but still needs accommodation that the school must provide. So, a student is considered qualified under the Section 504 of the Rehabilitation Act if the student is between the ages of 3 and 22 years of age and has a disability. And the disability is defined as a physical or mental impairment that substantially limits one or more major life activities. And major life activities include caring for oneself, walking, seeing, hearing, speaking, breathing, working, performing manual tasks, and learning. Some examples of impairments that may substantially limit major life activities, even with the help of medication, aids, or devices, include ADHD. I talked with a special ed teacher who gave me the following information. This is a game changer for me. I did not know this, so if the child is between 3 and 22, you have them call the school to get evaluated with an FBA or Functional Behavioral Assessment. The FBA is a process that identifies a specific or target behavior that interferes with students' education. The assessment attempts to designate the particular behavior, identify the factors that support the behavior, and determine the purpose of the behavior. A BIP, or a Behavioral Intervention Plan, is a written plan that teaches and rewards good behavior. It can be a single page or many pages. The purpose is to prevent or stop misbehavior, not just punish the child. So in 1997, an amendment to the Individuals with Disabilities Education Act included the language positive behavior interventions and supports, which described methods used to identify and support desired behaviors in the school setting. The educational research community has been developing and studying PBIS ever since. PBIS seeks to reduce or eliminate poor behavior school-wide through the encouragement of positive behaviors. We've already talked a little bit about parent training behavior management, but this is also known as parent behavior therapy, behavioral parent training, or just parent training. It requires 8 to 12 weeks with a trained therapist where the parent is taught skills. It incorporates principles of maintenance and behavior therapy and explains how to respond to relapses. It improves the child's functioning and behavior, but does not necessarily achieve normal behavior. Unfortunately, this is not provided by the schools as it is not covered by education and disability laws. In addition, most insurances will not cover this. Now we are moving on to pharmacologic treatment. Some general considerations for treatment of ADHD for children are: consider stimulants first line. Methylphenidate is generally recommended for children and teens because research shows it causes less stomach upset, has fewer effects on appetite, and causes less insomnia compared to amphetamine-type medications. View alpha agonists as second line or use them as augmenters to a stimulant, such as when you see only a partial response from a stimulant or if you are limited in dosing due to side effects. Use agents such as Strattera, atomoxetine, and Wellbutrin, bupropion, as third line. Start with the lowest dose. You can deviate from this depending on contraindications or comorbidities, but most children do well on stimulants. Ultimately, the recommendations that you land on depends on individual tolerability. I recommend starting with methylphenidate product and then trying a second one before going to a more amphetamine product, which can often be more potent with more appetite suppression, irritability, and withdrawal symptoms. Start with any of the long-acting methylphenidate products, including medications such as Concerta, Metadate CD, Ritalin LA, and Focalin XR. According to the latest guidelines from the American Academy of Pediatrics, consider starting with a short-acting med, such as generic Ritalin. I must say that this is different from what I see in practice. I usually see Adderall, which is a mixed amphetamine in practice, but I think a lot of this has to do with insurance coverage. They will cover Adderall most of the time and not some of the other products. But if you have the options, the newer liquid, chewable, and dissolvable ones seem great for children who struggle to swallow pills. However, again, insurance doesn't cover them, and I will talk about some system barriers later. With some generics in Adderall XR, Metadate CD, Focalin XR, and Ritalin LA, it works well to snip the capsule and pour the beads into a spoonful of something with decent consistency, such as yogurt, oatmeal, or peanut butter, just not a liquid, to ensure that the child gets all the beads. For many children, the symptoms disappear as they go into adulthood. However, 30 to 60% of those diagnosed with ADHD as a child continue to meet the criteria as an adult. ADHD affects around 5% of adults. Adults may need some other diagnostic tests to rule out potential causes of their persistent symptoms. And then there are some studies that show that amphetamine-type medications may work better in adults. Basically, there are two types of pharmacologic treatment: stimulants and non-stimulants. There is an extensive list in your required readings. The list is more for your reference than anything. In children aged 4 to 5 years, behavior therapy administered by the parent and/or the teacher is the recommended first-line treatment. If moderate to severe functional disturbances continue despite behavior therapy, then adding methylphenidate may be considered. My experience is that Medicaid will not pay for this, and I've had to use Adderall. For ages 6 to 11, a stimulant medication is recommended, preferably in combination with behavior therapy. That could be parent and or teacher administered. Non-stimulant options such as atomoxetine, extended release guaifenesin, or extended release clonidine may be considered as alternatives. However, the evidence for benefit is not as strong in this age group. Methylphenidate is supported as the first-line stimulant choice for patients 5 to 18 years old due to its similar effectiveness and better tolerability than amphetamines. For adolescents with a history or signs of drug misuse, diversion, or abuse, treatment options include non-stimulants or stimulant formulations with less abuse potential, such as the lisdexamfetamine, transdermal methylphenidate, or osmotic release oral system methylphenidate, preferably with behavioral therapy. In adults, amphetamines are supported as the first-line treatment due to greater effectiveness and equal tolerability compared to other ADHD medications over the short term. Bupropion is an antidepressant used off-label to treat ADHD in adolescents or adults when stimulants are ineffective or poorly tolerated, or for patients who could benefit from an antidepressant. Prescription stimulants increase the activity of the brain chemicals dopamine and norepinephrine in the prefrontal cortex and elsewhere. Stimulants stimulate and increase the release of certain neurotransmitters, most notably dopamine and norepinephrine, and block or slow up how much of these chemicals are being reabsorbed back into the neuron from which they were released. Methylphenidate primarily blocks the reuptake of dopamine and norepinephrine. Amphetamines mostly increase the release of dopamine and norepinephrine from their storage sites into the synapse. In the correct dose, stimulants improve symptoms within 1 to 2 hours for 3 out of 4 people who have ADHD. Stimulants are broadly divided into 2 main classes, amphetamines and methylphenidate. As I already stated, stimulants improve symptoms with 3 out of 4 patients showing significant improvement in symptoms. In comparison, only 1 out of 2 patients significantly improves when treated with non-stimulants. Stimulants improve prioritization of tasks or executive functioning, regulate arousal, and sustain attention for improved performance. However, stimulants are not universally effective or well tolerated in all patients and are often inappropriate for those with active substance abuse. Once-daily stimulant formulations are recommended for most individuals due to convenience. There's no need to dose during the school or workday and better medication adherence. Most once-daily products provide 8 to 12 hours of symptom control. Patients who take immediate release formulations require 2 or 3 daily doses because of shorter half-lives and duration of action. Immediate release formulations have the advantage of lower cost, less insomnia, and potentially fewer growth effects versus extended release products. However, they carry a higher risk of diversion and abuse. Nausea, stomach upset, decreased appetite, weight loss, insomnia, and headache are the most common side effects occurring in 10 to 50% of individuals who take stimulants. Usually the intensity of these effects decreases over time, so they have to stick to it. They say the heart rate only increases 3 to 10 beats per minute, and the blood pressure only increases by 2 to 14 millimeters of mercury. I don't see much increase in blood pressure, but their heart rate is notably increased. So I think it's more than 3 to 10 beats per minute. Stimulants may worsen anxiety and depression, cause mood swings, or trigger psychotic symptoms, particularly if they have an existing or underlying mood or psychotic disorder. There is some small reduction in height and weight trajectory while taking stimulants, but the long-term effect isn't known. Dose-dependent growth deficits of 1 to 1.5 centimeters, which is about a half an inch per year, have been observed with short-term stimulant treatment in children, and that's only during the first 2 years of use. Weight deficits are more prominent, with an average of 6.6 pounds weight decreased in the first year of treatment and 2.6 pounds weight decreased in the second year of treatment. The proposed mechanisms of stimulant effects on growth include alterations in growth hormone or growth factor, decreased thyroxine secretion, and suppression of appetite, leading to reduced caloric intake. Here are some suggestions to manage stimulant side effects. I am not going to go over each one of these. I think that you are able to read them and not listen to me babble on. The CNS stimulants that include methylphenidate and amphetamines have a high potential for abuse and dependence. So you have to assess the risk of abuse prior to prescribing and monitor for signs of abuse and dependence while on therapy. Long-term abusive use can lead to marked tolerance and psychological dependence with varying degrees of abnormal behavior. The DEA has this as a Schedule II, and that means it has significant abuse potential. Now, to counteract that, the treatment of ADHD with stimulants in childhood prevents or delays the onset of substance abuse throughout the teenage years. However, this lowered risk may be lost when a child reaches adulthood. While it is uncommon for teens and young adults with ADHD to abuse their own medication, they may share or sell medication to others who misuse it. College students often illegally purchase stimulants from peers to cram all night for an exam or to improve alertness for test taking. Individuals who abuse stimulants require higher doses than those prescribed for ADHD to achieve or maintain their high. Recreational users may crush and snort ADHD medication in an attempt to seek a high. I do want to emphasize that these patients must be followed up with urine drug testing at every visit. Almost 3/4 of the U.S. counties have no child and no adolescent psychiatrists. Almost half do not even have a pediatrician. As a result, many primary care providers lack an adequate pool of pediatric behavioral and mental health specialists who can accept referrals to treat complicated pediatric ADHD patients, and an adequate pool of behavioral therapists to provide evidence-based behavioral interventions. There are some impediments for payment that include restrictions to medication treatment choices such as step therapy, previous approval, narrow formularies, and frequent formulary changes. Some payers define ADHD as a mental health problem and implement a health insurance benefit that bars primary care physicians from participation. This designation results in denial of coverage for primary care ADHD services. Some payers have restrictive service and/or medication approval practices that prevent patients from receiving or continuing needed care and treatment. Examples include approval of only a limited number of specialist visits, limited ADHD medication options, mandatory step therapy, frequent formulary changes resulting in clinical destabilization, and disproportionately high out-of-pocket copays for mental health care or psychotropic medications. Okay, here are the key clinical considerations. So, efficacy, onset of action, duration of action, and tolerability are all important factors when establishing an ADHD treatment regimen and deciding between agents. Although both stimulants and non-stimulants provide significant improvement in symptoms, stimulants are more effective overall than non-stimulants. Stimulants generally have a faster onset of action, while non-stimulants take up to several weeks to reach therapeutic effect. Stimulants may exacerbate tics, anxiety, or substance use disorder, so they should be used cautiously in patients with these conditions. Stimulants can be associated with both rebound and withdrawal effects, and non-stimulants may be better tolerated, especially in children who experience issues with sleep or appetite when taking stimulants. Thank you for your time and attention. I hope that you learned something about ADHD. I know that I did.